Welcome to the Royal College of Physicians of Edinburgh. My name is Daisy Cunningham and I am the Heritage Manager here at the college. And I will obviously hand over to our speaker very, very soon, but I'm just going to take this opportunity to do a tiny little plug for a couple of things first. We have a whole range of events for young people and for adults. We have free school lectures coming up for young people who are thinking about a career in medicine. And we also have coming up on the 5th of November, Scotland's Opium Secrets as well. So check out some of our events, have a look at our free public gallery as well. But yes, so that's my plugs over. So I am chairing this event, so I'm very pleased to introduce you to our speaker, Dr. Hannah J. Elizabeth. They are a cultural historian of emotions, childhood, sexuality, and health. And as they pointed out to me, as every young academic has to do, they specialize in about 17 different subjects, including a very impressive range of smoking, polio, fuel poverty, lesbian health activism, and zombies, which is quite an array of specialties. And they have also just started, I think, last Monday at the University of Strathclyde. So we've got them a very busy time in their career. So yes, I just want to hand over, and Hannah will tell us all about Scotland's HIV history. Thank you, Hannah. Well, not all about it, about a lot of it.
Yeah, so I obviously have worked on a lot of different subjects in the history of health, but my main specialism is on the history of HIV and AIDS in Britain. And today I'm going to be drawing from my most recent research, not my brand new one that I started on Monday, which was on the history of HIV-affected family life in Edinburgh. So this paper will trace women's experiences of HIV and AIDS in Scotland in the last 2 decades of the 20th century, with a specific focus on the AIDS crisis in Edinburgh and women's experiences of care and activism as part of HIV-affected families. So today I'm hoping to kind of concentrate on the more hopeful side of this history, but I'm perfectly happy to take questions on the kind of more complicated histories of love, care, activism, and family, which have formed part of my research. So family obviously was not always a safe or caring space. Love is not always a force for care or good. And the social and medical care sectors didn't always get things 100% right. So that is part of this talk, but I really am trying to look for the kind of empowering elements of this history today. And saying all that, I do want to flag that some of the material that I discussed today might be a bit distressing. So I'm going to talk about some media representations which were incredibly stigmatizing and reference some difficult birth experiences. I'm going to flag this up ahead of time, so if anyone doesn't feel like they want to deal with it in that moment, feel free to kind of look away, stare at the ceiling, pop some headphones in, whatever you need to do. I won't mind if you leave the room or whatever. I will give you warning. But anyway, today I'm going to look at how HIV-affected women's health needs and needs as carers were met by the creation of new organisations, resources and activism. I'll explore the ways that the lives of HIV-positive mothers in Edinburgh were shaped by interdisciplinary, collaborative HIV/AIDS care and activism born out of the daily fight for resources, information, space and empathetic treatment for them and their families. Work such as this was often indistinguishable from survival or best practice. It occurred in the clinic and the home, and in acts of care performed by both medical and social care practitioners, but also by family members. And it also included the voicing and documenting of what women actually needed. This type of work, whilst different from the equally important protests and campaigning, which form aspects of the history of HIV and AIDS, which have been documented by scholars such as Matt Cook and George Severs, and more recently, Sonak Biswas, this kind of more quiet activism needs acknowledging and is part of the kind of important history of HIV and AIDS, but it was often a little bit more low-key and low-profile, and so sometimes it gets a bit more missed. This work can be traced through a wide variety of texts and archives, and was at the very least a backdrop for many women's experiences of HIV and AIDS in Edinburgh. Now, obviously, this paper will be a bit of an overview, but I'm going to try and offer some interesting details to stick all of these stories together. I'm pretty sure that some of the oral histories I quote today might be from people who are in the audience and people that members of the audience will know. So I hope that won't feel too awkward and uncanny to hear your words echoed back at you. Let's begin properly. So I'll begin my paper by sketching the situation in Edinburgh for HIV-affected mothers, outlining the tone of government and media interventions, the medical and social care needs of women, and the facilities which emerged to meet them. Here I'm going to focus on the challenges that many women faced and how women's needs for care, information, and community were then met. To look at care, I'm going to sketch the social challenges women faced and what social services then tried to focus on in order to meet these challenges, before moving the discussion on to how medical and information needs were met by health workers, looking at city hospitals, paediatric AIDS clinic, and the Paediatric AIDS Resource Centre in particular. So my final case study that I'm going to look at is the Citywide Family Support Group, which was a small activist group, which offers a really lovely example of the kind of community building that was part of HIV-affected women's activism. And then I'm going to offer some brief conclusions. I just want to acknowledge that in focusing on women's experiences as mothers particularly, there are stories which can and cannot be told. Women's lives beyond their families sadly don't find much space in the paper today. And while children's needs do feature, the voices of other key individuals in the lives of HIV-affected women haven't found much space here. Partners, extended families, friends, lovers, all shape the experiences of HIV-affected mothers, as did the myriad health and social care workers who engaged HIV-affected families. I also want to acknowledge the queer expertise which was fundamental for fighting for the rights of HIV-affected people, and profoundly shaped the delivery of HIV care and education in Edinburgh. The voices of LGBTQ activists require far more space than this paper allows, and it's part of the history that I have been writing, but this paper just reflects a small aspect of my work on HIV/AIDS in Scotland. Okay, with all that said, let's start properly. Okay, sorry, I was going to give you a bit of a warning about this slide, because it's obviously got a rather nasty Daily Mail article sensationalising HIV. So Scotland's experience of HIV and AIDS, whilst regionally and internationally inflected and influential, was demographically, culturally, and politically distinctive. So, for example, of those with HIV in Scotland by 1991, some estimates suggested that 63% had contracted the virus through either heterosexual intercourse or needle sharing, versus 24% for the UK as a whole. Edinburgh as a city was disproportionately affected by the HIV and AIDS crisis in the early 1980s and 1990s, earning it the unhappy title of AIDS capital of Europe in some of the worst newspapers. And as you can see from this clipping, which is from a 1986 Daily Mail article, the scale and the shape of the city's emerging AIDS crisis was making the press. The newspapers were interested. Partly, Edinburgh made the press because its crisis was recognised relatively early on. The retrospective retesting of blood samples in 1985, collected from IV drug users before the emerging epidemic was known about, indicated that between 1,000 and 1,500 IV drug users contracted the virus between the summers of 1983 and 1984. This finding was widely publicised, written about in the medical press, but also picked up by the popular press, partly because health and social care workers found this out and then began responding rapidly to the anticipated needs of this population. The press was also interested in the city because Edinburgh's AIDS crisis followed a slightly different pattern from that which was unfolding in London, with new infections predominantly occurring amongst intravenous drug users and heterosexuals, as I said, rather than, as in London, men who had sex with men. Indeed, in 1985, an estimated 50% of known injecting drug users, meaning those engaged by social, medical, or criminal justice workers, so the folks that people knew about, were thought to be HIV positive. By 1987, Edinburgh accounted for around 30% of all cases of recorded HIV among women in the UK, and Edinburgh had the highest rate of recorded HIV cases in the UK overall. Those women identified as living with HIV were often young and many had children or actually discovered their HIV status during the course of their pregnancy. As a result of all this, by 1993, there were around 500 known HIV-affected children with complex care needs living in Edinburgh. Again, HIV-affected women and children often made the press, making Edinburgh a particular subject of curiosity. But it's also clear that this early recognition of women affected by HIV living in the city created a kind of concentration of expertise, activism, and resources designed to meet their needs and the needs of their family. Obviously, these statistics are all a bit wobbly. Accounting for and meeting the needs of those who had HIV, recognizing who they were, was quite difficult. Social workers working with HIV-affected people in the 1980s and 1990s stressed that all these estimates were likely missing many HIV-affected families. Children affected by, rather than living with, HIV were even less likely to end up in the statistics. Essentially, HIV-negative children of HIV-positive parents might not get counted, despite what was clearly a potential significant kind of social need for them. Even more concerningly, parental status was not always asked of newly identified HIV-positive adults, and children with non-parental close relationships to someone living with HIV or AIDS largely went unrecorded, with some children even going uncounted in the statistics if it was their father rather than their mother that was living with HIV. So essentially, you could be a child living in a family with your uncle as your main carer, and you don't count as someone that we need to pay attention to in social care. Indeed, in 1991, social worker and expert on the familial dimensions of HIV and AIDS, Naomi Huntingsborn, charged the unclear collecting and reporting of statistics with creating a falsely optimistic view around the infectivity of children. These statistical deficiencies are important because they affected the distribution of funding for HIV-affected families, essentially hiding social needs and the needs of HIV-affected family members who didn't fall under the purview of medical treatment or transmission prevention. Now, despite these quantitative difficulties and these slightly wobbly statistics, it's clear that in Edinburgh, women and children were affected by, and in some cases living with, HIV in higher numbers than elsewhere in the UK. As a result, Edinburgh became a hub of activism and expertise as the HIV-affected and those who cared for them scrambled to address previously unmet needs. Indeed, it's clear that those working in the city were very aware of the gaps in the data, knowledge, care and funding, and were working hard to fill them through collaboration with the voluntary sector by specifically seeking out and collecting this information. Now, it's worth noting that differences in response to HIV were not the only thing that shaped women's experiences of HIV in Edinburgh. Women's experiences of living with the virus or on communities affected by it weren't just shaped by local responses or newspapers, but also the government's response had a profound impact on attitudes to HIV, shaping fears and expectations of who could be at risk of the virus, what they could do about it, and what kind of life they could expect as someone newly diagnosed as HIV positive. So national education campaigns produced by the Health Education Council, Department of Health and Social Security, and later the Health Education Authority, across the late 1980s and early 1990s, often focused on transmission and discouraged unprotected sex, and obviously IV drug use. Preventing new transmissions was obviously hugely important, but the needs of those at risk because they were surviving through sex work or already dependent on IV drugs, or those already living with the virus or caring for someone who was infected also needed to be addressed. I just wanted to give you some examples of this kind of public health campaign and what they were targeting, which helped shape perceptions of HIV and drug use in this time period. So from 1985 to 1986, England's Central Office of Information ran the Heroin Screws You Up campaign, deploying what would be described as kind of shock and horror tactics. This was matched in Scotland by the more optimistic Scottish health education group Choose Life Not Drugs campaign, which may seem slightly corny when they're put next to each other, but I think it's really important to pay attention to this slightly more positive perspective that was taking place. Both were aimed at reducing IV drug use, but both met criticism for failing to grasp the social deprivation which led many to become drug users or the circumstances which resulted in a kind of persistence in drug dependence. Similarly, when the DHSS attempted to tackle AIDS with the foreboding Don't AIDS AIDS campaign, running from 1986 to 1988 and featuring the infamous Don't Die of Ignorance television advert, balefully voiced by John Hurt, the Lothian Health Board offered Edinburgh's citizens their own health campaigns. Lothian Health Board and Lothian Regional Council HIV-AIDS team first ran the more inclusive AIDS Concerns Us All campaign from World AIDS Day 1988, and then a few months later launched the similarly upbeat Take Care campaign, began with much fanfare on Valentine's Day in 1989. And this is the campaign that people tend to have a bit of a memory of because of the Take Care buses and the brightly coloured adverts. These more empowering responses from the Lothian Health Board form a remarkable contrast with the Westminster government's responses, but they were also pushing back against media reporting on Edinburgh's AIDS crisis. For women experiencing the effects of HIV and their families, this more inclusive approach was really important, but the impact of messaging from the media can't be underestimated, especially on those women who discovered their HIV status during pregnancy or soon after birth. So just to give you a bit of warning, the next slide has some clippings from some pretty stigmatizing media coverage. And I'm going to discuss some of the impact of this kind of coverage and some poor birth experiences over the next couple of minutes. Now, as I said before, the media was especially interested in the AIDS crisis in Scotland, and particularly Edinburgh, because of the demographic differences between the city's crisis and those occurring elsewhere. But the media was also very curious about the lives of women affected by the virus and children born with it. So here we have a compilation of just a few headlines, which are really fairly typical of the newsprint media reporting on HIV-affected motherhood across the 1980s and 1990s. Even as the prognosis for babies born to HIV-positive folk started to improve, you still had these very persistent negative narratives. I want to apologise for the lack of labels. So the first one at the top, a child doomed to be an orphan, is from The Times. It's from 1993. The second one, AIDS Baby Nightmare, is from the Daily Mirror in 1985. And the third one, A Generation Born to Die, is from The Times again, from 1986. So for women who had newly discovered their HIV diagnosis, this kind of media reporting had a profound impact, implying that motherhood was impossible and that any babies they might have would be likely to be HIV positive and eventually be orphaned. Indeed, many women who went on to have successful pregnancies would reflect on the way the media shaped their earliest experiences and knowledges about HIV, instilling a sense of fear and guilt, which interactions with health and social care practitioners and activists had to work very hard to kind of push through this kind of real sense of fear. Building systems to provide care, information, and community then were not just about meeting medical needs, but also emotional ones in the face of a stigmatizing and pessimistic media. It wasn't just the media which shaped women's more negative experiences. Poor experiences around diagnosis and birth were also sometimes form barriers between women and health and social care workers. As one Scottish HIV-positive mother diagnosed at 3 months pregnant later recalled, and I quote, "The medical staff at the time were very negative. They made me feel worthless, really. Everyone expected me to get an abortion, medical staff, the whole lot. The way I was treated at the time made me feel worthless," end quote. So in the early years of the crisis, folk were advised to terminate their pregnancies, in part because it was believed that pregnancy could potentially accelerate the speed at which an HIV-positive person would develop AIDS, and that the mother and baby transmission rates were as high as 50 to 80%, with the prognosis for pediatric AIDS very poor. Despite this advice, many HIV-positive women obviously continued their pregnancies, and HIV-positive women continued to become pregnant, even knowing they were HIV positive. So the need for dedicated services in Edinburgh grew as the 1980s progressed. Frequently, HIV-positive mothers reflected on continued feelings of guilt instilled in them by the media, even after the birth of a healthy child. While poor birth experiences were not universal, many women also spoke with anger that they felt, with anger they felt after experiencing poor treatment during birth, with experiences of isolation and barrier nursing particularly difficult, but also some oral histories document breaches in confidentiality, people being tested without their consent and then being told that they were HIV positive just after giving birth. And also a kind of sense of staff fear, like staff being afraid of them, is often kind of cited. One mother who recalled a particularly traumatic birth described it and the aftercare she received as the worst 4 days I've ever experienced, and acknowledged a lasting sense of culpability after the birth. And I quote, "I felt really guilty. In my head, I saw it as some form of abuse because I didn't realize at the time that she might lose the positive antibodies," end quote. Now, owing to these experiences and other vulnerabilities common to HIV-positive mothers in Edinburgh, those working with HIV-affected families had to tread carefully and rebuild trust where it had been damaged. While ties between the voluntary, activist and statutory sectors were key to achieving this, adaptation and research into what mothers actually wanted from health and social care services was also fundamental. So there's a lot of people asking women, what do you need? What do you want? Even without negative birth experiences, parents who may have encountered difficulty with social or healthcare services were often reluctant to ask for help for fear of being declared unfit parents, while intergenerational drug use within some families made the use of kinship networks for childcare more difficult. Essentially, they couldn't necessarily go to their mum or their aunt or their brother or their uncle and ask for some extra childcare. Families affected by HIV and drug use across generations also often face multiple losses as siblings and parents were affected by separation through state intervention, family breakdown, and obviously sometimes deaths. Children might have experienced neglect, embarrassment, or become carers to their parents or siblings, or in the worst case scenario, suffered the loss of a primary carer. So while the emphasis remained among social workers around keeping children with their biological or extended family, HIV-affected and HIV-positive children sometimes also ended up entering the care system because of these breakdowns. So this should all give you an idea of some of the challenges in Edinburgh, which were substantial, but now I want to talk about the response. So for social workers working with HIV-affected women, rebuilding trust in health and social care services often kind of took precedence in the first instance. So building this trust had to take place before any kind of supportive interventions could really get off the ground. And a lot of this support was focused on supporting women in their caring roles to ensure that their health wouldn't suffer because of their caring roles. For example, ensuring that a lack of childcare wouldn't prevent people from attending clinic appointments. Sometimes this simply meant signposting to specific services or useful activism, such as, people who could help with jobs, benefit, housing, creches for the children. Other times it meant helping women build ongoing care plans so that they wouldn't have to worry about their dependents' needs if they went into hospital for a long period or if they passed. Social workers and healthcare workers were also challenged themselves, we should remember, by working with a new disease and new clients, having to adapt and learn rapidly, working collaboratively with folks from voluntary and activist sectors, so new colleagues, new people, new disease. Part of this challenge was around information management. Confidentiality was obviously a key concern around HIV, and different elements of the health and social care sector had slightly different attitudes as to when HIV should be disclosed. The kind of who needs to know was not necessarily uniformly understood. But disclosures within the family was also a really key aspect of social workers' work with HIV-affected families. Many parents living with HIV found it very difficult to disclose the virus's presence within the family to their children for fear it would upset the child, or in case the child disclosed it unwisely and the family kind of consequently experienced stigma. And there were a couple of scandals where a child might tell a school friend and then the child ends up being excluded from school because of other parents' fear at the same school. And yet children often sensed something was wrong. You couldn't just keep this secret. They might also be ill themselves, so they did need to have some level of understanding. So for social workers, this was a key concern, managing the rights of the child to knowledge, but also managing the parents' right to confidentiality. Indeed, answering the question, what do we tell the children, became an important part of the HIV-positive women's own activism, as well as the work of social workers working with families. So that's the social care side of things, but what about medical care? Obviously, that's a huge part of this history, so I'm just going to concentrate on what was happening in and around the city hospital's work with HIV-positive mothers. And I think Jackie's in the room, so I will be quoting. From October 1985, consultant paediatrician Dr. Jackie Mock had responsibility for monitoring and following up all babies born to HIV-positive women in the Lothian. At the time, some doctors were still too scared to work with HIV-positive and expectant mothers because, as public health consultant Dr. Helen Zeeley later explained in an oral history with herself and Mock, and I quote, "There's a lot of blood around when people deliver. People were terrified of blood," end quote. Mock herself recollected in the oral history that she was told by other doctors, and I quote, "Just keep your clinic down at the city hospital. We can't have them at sick kids." Despite this atmosphere of fear, uncertainty, and what Mock described as gloom and doom, over the next few years, Mock was among a small number of health workers in the Lothian tasked with figuring out how to meet the needs of HIV-affected families. Trying to bridge the knowledge gap around HIV-positive mothers and babies, Mock travelled to New York, New Jersey, and Miami in 1985 to look at what was being set up for children and their parents there. However, what she found was that while expertise was developing globally, little was known about HIV-positive mothers and babies, rather than mothers and babies living with AIDS. Many mothers in Edinburgh were found to be HIV-positive early on, but they weren't yet ill, so the new services were focused on monitoring healthy mothers and babies, as well as treating AIDS. So this is why one of the reasons Edinburgh is so important is because so much research developed around healthy people living with HIV. Postnatal and paediatric care took place inside and outside the hospital clinic, with home visits forming a key aspect of the care and monitoring, which structured the first few months of HIV-positive mothers and babies' lives after a new birth. At first, Mock and Dr. Ray Brettle, infectious disease consultant at the City Hospital, thought they could hold a kind of family clinic so that when parents came in, they could bring their children. But, and I quote, "Because the parents didn't come, the sort of family clinic became a mishmash of some clinic appointments and mainly home visits," end quote. Established in 1986, initially the paediatric counselling and screening clinic ran 2 sessions a week, but Mock explained that these became community cases very rapidly because, and I quote, "Expecting these very chaotic families to bring their children just didn't work. People basically weren't turning up. They weren't keeping appointments. Indeed, less than 20% of the families actually enrolled there used the paediatric HIV service outpatient clinic, with many preferring the home and as a more convenient and kind of less distressing place. Other families decided to keep the home a sanctuary of normality, free from, surveillance, medical intervention, choosing instead to use GPs' offices, health visitor clinics, or even children's nurseries. By allowing parents to choose the location of clinical encounters as far as possible, much needed trust could then be built, and the burden of what was quite intense surveillance could be lessened a little bit. While locations differed, the regime of medical testing and surveillance and treatment was fairly similar. When the European Collaborative Study into Paediatric HIV was initiated in 1985, Edinburgh was one of the first centres to join, quickly enrolling babies into the cohort study. The standard tested protocol for babies included in the European cohort study was onerous. Each baby, as Mock explained, and I quote, needed something like a follow-up at 1 week, 3 weeks, 6 weeks, then 6 weekly until 6 months, 3 monthly until age 2 years, and then 6 to 12 monthly. We also had to speak to the mothers in the antenatal period to seek their consent, to explain to them about the purpose of the study. Nobody actually withdrew consent. They were all very willing, they were interested. Actually, they were very thankful that someone was interested in them and their children. So you can see that this real need for care is there, and then we have this kind of collaboration and intervention. As well as the intrusion of health workers and sometimes social workers into the home to facilitate this kind of testing and surveillance regime, the physical nature of these tests also caused some difficulties. Mock admitted that, and I quote, "it was a lot of blood," end quote, being taken from small babies. While she remembers that mothers were often very compliant, it was fathers who often became distressed, leaving the room, getting angry when taking the blood didn't go well enough, when the baby started crying. That's when the men used to get quite distressed. Mock remembers being shouted at when attempts to take blood from babies didn't come off first time. The pressure to get it right obviously increased by some increasingly distressed parents in the room. Despite these difficulties, by entering the home and offering consistent monitoring, which went beyond just simple HIV testing, medical practitioners were able to build this much-needed trust. This trust meant that services run out of the city hospital's family clinic could be adapted to bridge other gaps in healthcare, because many of these families weren't attending the routine clinical appointments that you might expect. They added normal screening appointments to the kind of HIV rota. So to quote Mock, they got the developmental screening, and then I would take a clinical history to make sure they were okay. You can imagine the anxiety among these young women. Any snuffle, they might be on the phone to you. Any contact with chickenpox, they might be on the phone to ask for advice. They didn't go to the GP. They always bypassed the GP. They'd come straight through to the paediatric clinic. So you can see the way that this trust has kind of meant that the clinic stood in for everything in this instance. So this was more than about kind of information and reassurance and research. This was about building trust and doing something different. And it was quite innovative, I would argue. Now, the innovative nature of Lothian's response to HIV among mothers and babies meant Mock soon began to receive requests for information on all aspects of paediatric HIV, not just the clinical aspects, from interested parties from the UK, Europe, and around the world. This was something useful. So in February 1991, the Paediatric AIDS Research Centre was established using some short-term funding from the UK's children's charity, Barnardo's, and from the European community. Now, interestingly, as with many AIDS activists or charities and foundations, Park never received long-term funding, instead relying on a variety of small grants and collaborations with other HIV organisations. The explicit aim of the Paediatric AIDS Resource Centre, or Park, was to improve the care of children and families with HIV by providing information for anyone involved in their welfare. According to its profile in the Lothian HIV/AIDS newsletter Meridian, it achieved this by publishing and distributing leaflets, responding to telephone and written personal inquiries, organising training courses for groups of child carers, and holding annual meetings. So we've got this real emphasis on information giving, but also on kind of building different communities and building links. To realise these ends, Park helped facilitate and support the work of other organisations striving to meet the needs of HIV-affected families, enabling charitable and activist organisations to reach wider audiences because of their links with Park. For parents affected by HIV, Park collected together several leaflets written by Dr. Mark and Fiona Mitchell to form a parent information pack. Now, this pack included quite a large number of leaflets explaining HIV as it pertained to parents and children, explaining expected regimes of testing and treatment, and also other useful information for anyone involved in caring for an HIV-positive child. Partially, Park's leaflets aimed at HIV-positive parents functioned to kind of prepare them for medical encounters inside and outside the home, securing ongoing consent for health interventions such as tests and treatment. However, because of the media's persistent interest in HIV-positive mothers and their babies, the leaflets also worked to redress misinformation and stigma, empowering HIV-affected families and attempting to instill a sense of hope. So, for example, in one of the leaflets, "I'm HIV positive, what does this mean for my child?" Scientific facts are communicated in simple terms, as we might expect, but also one of the aims of a follow-up session is described as to reassure parents where possible that their child has no signs or symptoms of HIV infection. These leaflets were also designed to have kind of a reassuring feel. So there was a green and white leaflet decorated with teddy bears, dressed as doctors, dressed as doctors, nurses, and patients. And this explained all babies born to HIV-positive mothers will at first be antibody positive, before reassuring parents that the City Hospital has been following up on babies born to HIV-positive mothers since 1985. So far, around 10% of these babies are infected with HIV. So this pushing back against this idea that transmission is inevitable. After this important framing that transmission wasn't inevitable, the schedule of intense assessment required for babies born to HIV-positive mothers is then given. So we have reassurance and then the facts, followed by a list of what these assessments might involve. These leaflets acknowledge the onerous nature of medical scrutiny of HIV-affected families. They thanked parents for their cooperation and reassured parents that, and I quote, "all information regarding you and your child will be treated in the strictest confidence." So that sense of the importance of confidentiality was out. Leaflets such as these acted as reference material, allowing HIV-positive mothers to process their diagnosis and a future regime of tests for their babies outside of the clinical encounter. That was something they could take away and think through in their own time. Within the clinical encounter, they also provided a simple script for care practitioners to use, reassuring parents and persuading them to participate in the really important cohort studies. Armed with the knowledge provided by doctors, leaflets such as this also allowed women to adequately plan for their future. They knew what was coming. These interventions had meaningful impacts on HIV-positive and HIV-affected mothers. We know this because they talk about these moments in the clinic, this giving of leaflets in their oral histories. And often this reassurance rejects some of the hopelessness engendered by the media representation. So as one adoptive mother of an HIV-positive toddler would explain, and I quote, "We had a doctor from the Fife Health Board out to counsel us on the virus and realised what the papers were printing on how you catch the virus was very wrong." Alongside the creation of published material, Park maintained a large collection of resources on a wide range of topics that would be important to children affected by HIV. It also maintained 2 databases, a medical scientific database and one collating information on other organisations and resources. Though originally envisioned as primarily an information centre and a way to formalise the kind of signposting that had become part of so many folks' jobs, Park began to organise training days and support kind of further publication. Park was proactive in its approach to meeting the needs of HIV-affected families in this way. So after a UK-wide needs assessment of services, Park's coordinator, Alison Angus, in 1994, put forward some funding to create resources not just for HIV-positive parents and kind of carers, but also for HIV-affected children themselves. In part, these resources aim to overcome the reticence guardians had around talking about HIV to their children, filling gaps in education for HIV-affected children and empowering those who cared for them. But also, they were specifically for the children themselves. So, this meant asking parents, in order to do this, they had to go and ask parents and children, where possible, what they needed. It also meant facilitating the creation of resources by HIV-positive mothers themselves. And it meant creating stuff like this activity pack, which we have on this slide. So Park responded to parents' requests for books to help them open up regarding HIV and for books that will help them explain the virus, producing or facilitating the publication and dissemination of several texts, both factual and fictional. Among these was It's Clinic Day, a picture book by Ruth Stevens, an HIV-positive mother. Now, obviously, HIV-affected women were engaged in loads of different kinds of activism to help themselves and to help others, but this book is a pretty special example. Stevens came up with the idea for the book to fill a gap in resources for HIV-positive parents tasked with talking about HIV to their children in a sensitive manner. So the book follows a mother and child visiting an HIV clinic, modelled on the City Hospital's clinic. By showing encounters with other HIV-affected children, happy interactions with paediatricians and health visitors, and delivering simple information about HIV, the book modelled a kind of ideal clinical visit, and even scripted a parental HIV disclosure so that a reticent parent could literally read this book to their child and get that conversation going. So on the slide, we've got a few highlights, but I've actually brought 2 copies of the book with me, so if anyone wants to have a look at this picture book, I have got 2 copies so you can have a peruse. So here we've got Jane having her routine, Jane's the little girl, having her routine tests done with the very friendly Dr. Green in a colourful clinic room. On the wall, you actually have posters for the Women and AIDS HIV Network, hanging up with the kind of standard colourful decorations you might expect in a paediatric clinic. Now, this is obviously quite a small detail, but the poster would have been a signal to any parent reading the book to their child that there was a community out there was activism out there, they weren't alone, other people were doing things and they were there for their support. In the book, when Jane asks her mum, or the doctor, or any other adult a question, it's answered freely, in simple terms. This includes child-friendly, simple explanations of tests, the virus, and AIDS-related prejudice. So the book offered a script for parents and healthcare workers explaining the virus and any necessary tests, but also it acts as an argument that children needed to be informed about HIV if they lived in a family affected by it, and also an example of this is possible, you can disclose HIV to your child, it can work. While Park concentrated on the needs of mothers with young children and others worked to meet the needs of While Park concentrated on the needs of mothers with young children, others were working to meet the needs of parents with adult children affected by HIV. So in 1980, Muriel and her husband Tom, the Hart family, learned that 2 of their sons were drug users. In an effort to find a way of helping her sons and others like them, Muriel became a volunteer at the North Edinburgh Drug Advice Centre. Soon Muriel then went on to discover that her 2 sons were both HIV positive. So during her time volunteering at the North Edinburgh Drug Advice Centre, Muriel found that she was continually being approached by parents and other family members of drug users, asking for support and kind of her knowledge, asking for what she knew around the stresses of family life, how to manage addiction within a family, and in many cases, how to manage HIV within a family. Working from their home in North Edinburgh, Muriel set up the citywide family support group in 1985 to kind of formalise this advice giving that she was already doing in order to share her own experiences with others throughout the city and to encourage others facing similar problems to kind of come together for mutual support and assistance and to share information. Now, this service boiled down to a kind of sharing of experiences and emotions for the most part. So this meant sharing cups of tea, answering the phone, and offering a space to discuss. The group offered a safe place for its users to express anger, grief, and sorrow, and to combat the sense of loneliness and isolation that was felt by many HIV-affected folk and their families and carers. As one user expressed, the group offered a place to feel normal. Muriel and volunteers worked together to take care of the day-to-day kind of running of the group and its services, which included attending hospital and home visits for people. Other friends, acquaintances, and group users offered assistance on a more ad hoc basis. So when it was needed, when a need arose, bridging gaps in services or family support networks by offering lifts, fetching shops, generally taking a kind of community-focused approach to needing needs when they arose and there wasn't someone there to meet them. This was as much about filling gaps and offering emotional support as it was about building community and empowering individuals. Indeed, the ethos of the citywide group was, and I quote, to create opportunities for those affected to become involved with assisting themselves and others coping with the problems of addiction and HIV/AIDS within their local community. So we have this real sense that it's about community building, but it's about empowerment. This isn't about other people helping, it's about you helping yourself. Okay. The lives of HIV-positive and HIV-affected mothers living in Edinburgh in the last 2 decades of the 20th century were shaped by a wide variety of factors. Against a backdrop of media interest in Edinburgh's seemingly unusual demographic spread of HIV infection, mothers' experiences were rendered the stuff of newspaper melodrama and misinformation, engendering feelings of fear and guilt in those newly diagnosed. What's more, despite the interest in mothers, their emotional needs remained neglected by a national public health response largely aimed at preventing new infection rather than meeting the needs of those already living with the virus. And yet, living in the AIDS capital of Europe meant access to medical expertise and dedicated paediatric services, which emerged relatively quickly in Edinburgh, specifically at the City Hospital. While other cities' medical responses concentrated on the needs of patients with AIDS, early recognition of a population living with HIV in Edinburgh created opportunities to differentiate and attend to the specific needs of those living with both HIV and AIDS. By looking at the challenges women affected by HIV/AIDS as mothers and how care, information, and community was built in Edinburgh, I hope this paper has revealed something of this often less told history. Thank you.